Welcome. It's really a big pleasure for us to be here today with you in the morning, in the afternoon, in the evening. Really, we have people joining us here today from all over the world. It's amazing how this Urticaria group is keep on growing and growing even every day bigger. And we are really happy to share today with you some of the latest results and latest data that have been presented just last year, the end of last year, in the GOOF forum. So today, the webinar is called Year-End Review, not Year-In Review, but it was the review of what happened at the end of last year, the GOOF forum. Well, what is the GOOF forum? The GOOF forum is Global Urticaria Forum, for those of you not so well familiar with the term. And this year it was held in Hiroshima, Japan. I will spend some more words on the next slide on the GOOF forum. It had several sections, and we will try to give today, with the 4 speakers we have here for you prepared, a summary of what the poster sessions presented, a summary of the lectures, a summary of the workshops, and also of the oral communications. And if we all do it correctly, there'll still be a little bit of time for you at the end to have some questions and answers. So first, what is the GOV? The GOV, now the Global Urticaria Forum. This has been held now since more than a decade back. Every time at the end of the year, it was first in Berlin, it's been sometimes in Barcelona, with Ana Jimenez Arnau chairing there. And this year it was held and coordinated by Michihiro Haidt, one of the top urticaria specialists in Japan. Misfortunately, as still in the pandemic, it had to be majorly online, but there were people, that was the good thing, as it was online, there were now really over 500 attendees linked in to the sessions. 45 different countries. So you can see, I'm really not exaggerating if we say we're here joining with people from all over the world. All over the world, people who have special interest in urticaria. It was a 3-day program. You really were hearing the latest of the latest. And just for those who still would like to have a look at the complete lectures, the website is still open to the 31st of this month, so still some days. Well, a summary of the poster sessions. This shall be given to us by Dr. Pavel Kolhier. Dr. Pavel Kolhier, he's a clinical researcher. He is working at the moment at the Department of Allergy in the Charité Universitätsmedizin Berlin in Germany. So we're really happy that Dr. Kolhier will give us the most interesting points, now put the spotlight on some of the points of the posters that were presented during the GOV. Then we go on to a summary of the lectures. And today, Dr. Mónica Rodriguez, a colleague of mine here in Mexico, she's an allergist and clinical immunologist. She's in private practice in Hospital Español in Mexico City, in Mexico. And she just became now, and congratulations with that, the Secretary General of the College of the Pediatric Allergists in Mexico. She will give us a summary of the lectures. Then we continue with a summary of the workshops, and that will be given today by Dr. Chuda Gujihararan Wong. I hope I more or less did the correct thing with your name, Chuda. Really happy to have you here with us from Bangkok, Thailand. She works at the Department of Dermatology in the Faculty of Medicine in Shri Raja Hospital in Mahidol University in Bangkok. And then the last part is a summary of the oral communications, and that has been prepared for us today by Dr. Isabel Oveta. Dr. Isabel Oveta, she works at the Pontificia Universidad Católica de Chile in Santiago de Chile in Chile. So she will give us a summary of the oral communications, and this was not easy because some oral communications were about clinical trials that are just more or less finished. So it's really unpublished stuff that was presented there. She checked back with each of the presenters which data we were able to share and not yet able to share today. So she will really give you the best of the oral communications, what is allowed to be shared here with you. So I think without any further delay, well, okay, this is myself. No, I'm Dr. Désirée Larenas-Linneman. I'm an allergist, clinical immunologist, and pediatrician. I work in the Center of Excellence in Asthma and Allergy. I'm a UCARE center in Hospital Médica Sur there in Mexico City, and I coordinated the Mexican guidelines on Urticaria, and also now a national course on Urticaria. But well, we hope to really learn a lot in the next 55 minutes that are left now. And without any further delay, I'd like to go now, please, to the first speaker, Dr. Pavel.
Thank you very much, Désirée, for your very warm introduction. Hello, everyone. My name is Pavel Kolchir, and I work at Charité Medical University in Berlin. And I'm going to present the summary of the poster session, as Désirée said. And so 102 posters were included, and they were distributed in 9 different categories, and you still can check them using this link below by the end of this month. So my task was to pick a few posters to present today, but actually it was quite hard to choose because there were a lot of great posters, but I tried my best. So the first poster is called Identification of Chronic Urticaria Subtypes using Machine Learning Algorithms. And presenter was Dr. Murat Turk from Kayseri City Hospital, Turkey. And Dr. Turk and his colleagues used machine learning algorithms, so-called cluster analysis, and they were able to divide patients with chronic urticaria. Actually, there were 337 patients into 4 different clusters. So first cluster included only patients with chronic inducible urticaria, and the second cluster might be more interesting because it consists mostly of female patients with high total IgE levels and high rates of comorbid atopic dermatitis. Next cluster, cluster third, includes patients, mostly females, with low levels of total IgE, high levels of IgG anti-thyroperoxidase, and high rates of antinuclear antibodies positivity. So most of you might know that 2 types of autoimmune chronic spontaneous urticaria are known. First type, so-called autoallergic urticaria, which is associated with IgE autoantibodies. And second type, or type 2B autoimmune CCU, is associated with IgG autoantibodies against IgE and its high affinity receptor on mast cells and basophils. And also we know that these patients show low levels of total IgE and high levels of IgG anti-TPO. So it might be that most of these patients which were included in this cluster 3, they are also patients with type 2B autoimmune CCU. And the last cluster, cluster 4, Dr. Turk and his colleagues called it high comorbidity cluster, consists of patients with high rates of comorbid diseases such as hypertension and diabetes mellitus. So the next poster was presented by Dr. Moica Bichak from University Clinic of Respiratory and Allergic Disease in Slovenia. And it is called Risk Factors for Systemic Reactions in Typical Cold Urticaria, Results from the Cold C study. So it was a global international study which involved 32 UCARE centers from 19 countries and 4 continents. And 551 patients with cold urticaria were included. Most of them had typical cold urticaria, so actually 75% of them, which was diagnosed using provocation test with ice cube and using temp test device. And what is more interesting, 37% of these patients with typical cold urticaria, they also had cold anaphylaxis. So, and the main aim of this study, which has been recently published in the Journal of Allergy, was to find out which factors are associated with severe cold urticaria and cold anaphylaxis. So, and there are several such factors. So, for example, generalized wheals, acral swelling, and itchy earlobes were associated with severe cold urticaria and also with cold anaphylaxis. And there were also some additional symptoms such as oropharyngeal, laryngeal symptoms, or systemic reactions. So cold anaphylaxis in the past, they were also associated with higher probability of having cold anaphylaxis. So, and the last study, the last poster was presented by me, but actually it was a great collaboration between Russian team and German team. It is called combination of IgG anti-TPO and total IgE is a useful marker for detection of autoimmune chronic spontaneous urticaria in everyday clinical practice. So, as I already said, there are 2 types of autoimmune CSU. One of these types is type 2B autoimmune CSU, which, as you may already know, is diagnosed by triple positivity. So basophil tests such as basophil activation test and basophil histamine release assay positivity, autologous serum skin test positivity, and positive and detection of IgG auto antibodies against Ig and its high affinity receptor using immunoassays. But unfortunately, these tests have limitations, so they are not available in many centers. Therefore, our goal was to check whether the combination of elevated IgG anti-TPO and low total IgE levels might be an alternative to diagnose these patients with type 2B CSU. So this study, which has been also published recently in JACI practice, included a cohort of patients with chronic spontaneous urticaria. 1,120 patients were included. And 11% of these patients had this combination of high IgG anti-TPO and low total IgE levels. As you can see in this figure, which depicts the association between the combination of these parameters and other markers, features of type 2B autoimmune CSU, such as basophil activation test positivity, basopenia, eosinopenia, positive autologous serum skin test results, presence of angioedema and antinuclear antibodies. And it was assessed by using chi-square test. And here you can see values of Kramer's V, which is a parameter for association of level of strength of level between different pairs of markers. For example, we can see that the combination of both parameters is strongly associated with basophil activation test, with basopenia, with eosinopenia, and also with positive results of autologous serum skin test. And here we also can see that these patients with high IgG anti-TPO and low total IgE, they also showed the highest percentage of CD63 and CD203C positive cells as compared to single positive patients or double negative patients. So, and this combination was also linked to other features of autoimmune CSU, as I already said. So these patients with this combination showed the highest rates of basopenia, eosinopenia, and SST positivity in addition to BOT positivity. And what is maybe more important, these patients are also patients who show high rates of non-response or poor response to second-generation antihistamines, which are first line of treatment of chronic spontaneous urticaria. So we could find that 30% of patients with combination, so that only 30% of these patients with this combination responded to second-generation antihistamines in standard dose or updosed. So to conclude, so we should further use these machine learning algorithms and cluster analysis, which can help us to identify different distinct subtypes and endotypes of chronic spontaneous urticaria. Cold anaphylaxis is common in typical cold urticaria, and we need to educate our patients how to use adrenaline autoinjectors and which factors are associated with high probability of having cold anaphylaxis in patients with cold urticaria. And the combination of high IgG anti-TPO and low levels of total IgG might be a useful diagnostic marker as an alternative to other markers of type 2B. But of course, we need additional studies which should confirm this. Thank you very much for your attention.
Thank you very much, Dr. Pavel. I think that was very nice, strictly within the time limit, the 12 minutes we gave you to present the best of the posters. If there are any questions, remarks, please put them in the chat and I'll check them when we get to the end of this webinar. I'd like to continue now with Dr. Mónica Rodriguez, who's going to give us a summary of the lectures. Dr. Mónica.
This is Mónica Rodriguez from Mexico City. First of all, I want to thank UCARE organizers for this kind invitation, as well as all attendees. At UCARE Galen 2021 last December, there were excellent talks about our current understanding on urticaria. Here, I tried to put some of the pieces together regarding pathophysiology and treatment for chronic spontaneous urticaria. And so, where do we stand now? What have we learned? At his lecture, Professor Markus Maurer spoke about the current roles of IgE in terms of activation of the mast cell. He very clearly explained the important role of IgE, auto-IgE, its high affinity receptor, how and very oftenly in patients with CSU, there are autoallergens, how these autoallergens bound to auto-IgE can form functional and circulating immune complexes. Furthermore, he detailed how auto-IgE can bind to cross-reactive, either auto or exoallergen. As well, Professor Maurer explained some very interesting recent data on how auto-IgE binds to its high affinity receptor, and as here it's shown, it can be via the FAB portion. Professor Maurer detailed the role of IgG, auto-IgG, when it's directed to IgE or to Fc epsilon R1, also in terms of mast cell activation. And this leads, as he explained, to the two main endotypes for chronic spontaneous urticaria, where auto-IgG drives the type 2B and auto-IgE drives the type 1. Moving forward into the lectures, Professor Romiseini spoke about the activation as part of the pathophysiology of CSU of another very interesting cell, the basophil. First, Professor Seini spoke about how two endotypes can actually coexist, as patients may present auto-IgG as well as auto-IgE, and from the clinical perspective, how autoimmunity can coexist as well as atopy on the same patient. When focusing to the basophil and how it can actually be a very useful marker for prediction of response to treatment, specifically to anti-IgE treatment, Professor Seini described the different biomarkers that are currently available, such as the measurement of total IgE, and he presented data and consistent data on how levels with a threshold above 18 can be associated with a better response to anti-IgE treatment and lower levels with a poor response to treatment. He also spoke about the inverse correlation between blood basophils and how higher levels are again correlated to a better anti-IgE treatment, and lower levels or vasopenia can be associated with a poor response to treatment. Professor Seini also spoke about functional characterization of basophils in order to identify patterns of response, as he very well detailed some research done by his group where ex vivo basophils derived from CSU patients were incubated with anti-IgE and then marked as basophil responsive or non-responsive in terms of the basophil histamine release assay being positive and negative, and how this in vitro test can be related to the clinical response to treatment. Moving forward into the lectures, Professor Bernstein spoke about the role of another very interesting cell, the eosinophil, and how it has also led to treatment targets. He, in a very detailed way, explained the close relationship between eosinophil and the mast cell, and how he described different mediators liberated by the eosinophil and how these keep up the very close and cross communication with the mast cell. He also spoke about looking into the quantitative tests that show eosinophil counts, either in biopsy and in baseline blood eosinophil counts in terms of response to treatment, again, anti-IgE treatment, but also in disease severity. And he explained and showed results on how lower levels might be associated with high disease activity and also with a poor response to treatment, and vice versa when the levels are high. He also showed some interesting data on biologic treatment targeting eosinophil, specifically anti-IL-5 receptor. As we know, this leads to an inhibition of recruitment, proliferation, and survival of the eosinophils. And he showed results on data from clinical trials where this intervention actually achieved primary endpoints in terms of disease activity as compared to placebo. His research group also deepened into our understanding on pathophysiology in regards to genes, as he spoke about cutaneous gene transcript networks and the impact of genes from skin barrier. And so we can turn into novel data on probable dysregulation of inflammatory pathways and downregulation of barrier function. Moving forward to Professor Alan Kaplan's lecture, where he very well detailed the role of the cellular infiltrate for the lesion formation in chronic spontaneous urticaria. As he very well detailed and explained every one of each of the described cells that have been identified as part of the cellular infiltrate. He spoke of the very classic effector cells, such as mast cell basophils, the chemokines and cytokines released by them, and the impact that they do have for the recruitment and activation of other very important inflammatory cells at the site of the lesion. Also, he described different chemoattractant molecules. He moved forward into other cells, such as lymphocytes, specifically T helper cells that are commonly found at the cellular infiltrate of lesions, and from T helper cells, the different subsets, such as Th2, Th17, not being the only one. He also spoke about Th1 and Th9, but the most important ones, and also how these may lead to other treatment targets. He spoke also about neutrophils and their role. He spoke about the ratio among neutrophils and lymphocytes and how this can lead to further information about endotypes and response to treatment in the patients. Also, he spoke about monocytes being found at the cellular infiltrate and how there is a poor understanding of their current role as part of the pathophysiology. Also, he explained how all these cellular infiltrate, how these immune cells lead to activation of the endothelial cell as they release vasoactive mediators. And whenever the endothelial cell is activated, it releases, there is a higher vascular permeability, and therefore there is a release or the plasma leakage leading to the classical hives and angioedema. Also, whenever the endothelial cell is activated, as he very clearly explained, there is a recruitment of coagulation factors, specifically via the tissue factor. And also how this inflammatory and vascular activation and response leads to the neurostimulation in terms of afferent neurons and the classical itch presented by the patients. Professor Thompson deepened on our knowledge on a biologic treatment. And he very clearly detailed how omalizumab is the only currently available and worldwide available biologic treatment for chronic spontaneous urticaria. It is an anti-IgE. Next in line, ligelizumab with a higher affinity, also targeting the FC3 portion from IgE, but with a more potency and more affinity. And also how results from clinical trials have shown high and sustained efficacy and safety. He presented some recent data after the phase 2 clinical trials on the extension study, where we can actually see the sustained results in terms of clinical control achievement for most of the patients. And this was achieved with a 240 milligram dose of ligelizumab with no new safety signals, and the phase 3 data will soon be available. He also spoke about other biological treatment targeting type 2 inflammation and some promising results still on phase 2 and some into phase 3 clinical trials. Professor Martin Metz spoke about the evidence on current status of small molecule treatment. As he very well explained, there are essential and key molecules that lead into the activation or downstream activation of immunoreceptors, such as SYK and BTK, which are intracellular protein kinase. And when inhibited, they also inhibit the activation via these immune receptors to some essential cells for CFU pathophysiology, such as Fc epsilon, R1 for mast cell and basophil, and BCR, of course, for the B cell. He spoke about results from the molecules inhibiting BTK, such as fenebrutinib, And he shows some results where we can very clearly see those response where it was notably effective and even comparable to anti-IgE treatment. Also, and he detailed how it was particularly effective for CSU patients with the type 2B, where there were there were results as there was a lowering in the auto-IgG targeting the Fc epsilon R1. And moving forward, he also detailed some results on remibrutinib, another BTK inhibitor, and how it has actually shown after the phase 2 clinical trials, strong and fast response. Finally, he also spoke on another topical inhibitor for SIC, where in the phase 1 clinical trials showed a clinical meaningful reduction in the critical temperature threshold for patients with cold urticaria. With this, I come to an end, and thank you very much for your attention.
Inspiring, a lot of pieces of this puzzle now that you try to show us, and how the lecturers gave us the little pieces, how they all come together. I think it's definitely worthwhile for those of you who were not able to join the conference to still pay the little fee to get registered and take advantage of these last 5 days that the lectures will be online. Okay, let's move on to Dr. Chuda. Please, the set is yours.
Hello, everyone. My name is Jnuary. Now, I'm working as a dermatologist at Department of Dermatology, Faculty of Medicine, Zurich Hospital, Mahidol University. Today, I would like to summarize the workshop sessions. This session composed of 2 parts, including the first one is the detail of patient-reported outcome measures in the Dicario and angioedema, and the second one is about provocation tests for chronic inducible Dicaria. What's important to use this instrument in the daily practice? The advantage of prompts is used to capture the patient's perception about disease activity, quality of life, and the response of the treatment. Focus on the Dicaria. We have the specific questionnaire for our patients. The first one is the Dicaria activity score that represents the disease activity. The UAS is the simple scoring system for the patient with chronic urticaria. The severity of views depends on the number of views in each day, as shown in the table. The same scoring system is used to evaluate the severity of itchiness, so that the daily score is calculated by adding together both scores. For 7 days, the maximum total score is 42 points. The UAS7 score are assigned to 5 score ranges, reflecting from the urticaria flea to severe disease activity as shown in this slide. Additionally, the minimum clinical important difference are coded as MCID of the US score is also reported. The description of MCID is the small change in the treatment outcome that each patient would identify as important. The MCID of the UAS7 score is approximately 10 points. The next one is the urticaria control test. The UCT is a valid and reliable questionnaire to assess disease control in the patient with chronic spontaneous urticaria and inducible urticaria. The UCT is a simple 4-item questionnaire. The minimum UCT score possible is 0, indicating no control, and the maximum score is 16 points, indicating complete disease control. The cutoff value of UCT score to characterize patients with poorly or well-controlled urticaria is 12 points. The MCID of UCT score is also reported as 3 points. To assess quality of life, we use chronic urticaria quality of life questionnaire. This questionnaire consists of 23 items, which are categorized into 6 domains, including itching, sleep problems, limitations, function, mental status, and swelling. For each item, patients are asked to choose between 5 response values, indicating the intensity in the last 2 weeks. The total score is calculated and transformed into a score of 0 to 100 points. A score of 100 indicates the worst quality of life impairment. These are specific instruments for evaluating urticaria. Next to angioedema, we also have the specific questionnaire for these patients. The angioedema activity score is used to assess disease activity in all patients with angioedema, including recurrent angioedema, hereditary angioedema, and chronic urticaria with angioedema. It composes of 5 patients. A minimum score is 0, and the maximum score is 15 points in each day. Higher score represents a higher disease activity. Next to angioedema control test, a 4-item questionnaire is used to assess the disease control. For each item, patients are asked to choose between 5 response values. The minimum AECT score possible is 0, indicating no control, and the maximum score is 16 points, indicating complete disease control. The cutoff value of AECT score to categorize patients with poorly or well-controlled angioedema is 10 points. We found that the AECT score demonstrates a high correlation with the frequency and type of angioedema, self-reported disease control, and quality of life impairment. The next is the angioedema quality of life questionnaire. It consists of 17 questions. Each question has 5 answer choices. The total score is calculated and transformed into a score of 0 to 100 points. A score of 100 indicates the worst quality of life impairment. Besides chronic spontaneous urticaria and angioedema, the specific questionnaire of chronic inducible urticaria has been developed. Now, there are 2 questionnaires about cholinergic urticaria. The first one is cholinergic urticaria activity score. This questionnaire asks a daily basic symptoms to assess disease severity. A higher score indicates a higher disease activity. Another one is the cholinergic urticaria quality of life questionnaire. There are totally 28 items to evaluate in 5 domains, including symptom, functional life, social interaction, treatment, and emotions. More than this questionnaire, symptomatic demographism and co-urticaria are still in process of questionnaire generation. You can get more information of all questionnaires in this website. Let's move to the second part of the workshop sessions to talk about the provocation test for chronic inducible urticaria. In this session, we talk about 4 provocation tests. The first one is temp test for using in cold and heat urticaria. The temp test device provides continuous temperature gradient from 4 to 44 Celsius. Please confirm the testing area should not be affected by urticaria in the last 24 hours. The patient should be performed by placing the skin on the device for 5 minutes and waiting for 10 minutes to interpret the results. The temp test also provides the information of stimulation time threshold and temperature threshold. This information is very useful for patients to avoid trigger situations in the daily life. Moreover, the physician can use the temp test to monitor the efficacy of treatment and adjust the medication. The next one is the FRIC test. It is used to test symptomatic demographism, which is the most common inducible urticaria. This instrument is a disinfectable plastic cone with a different length of 4 pins, so that it makes a differentiating force to the skin and allow us to determine the trigger threshold. For testing, the instrument is placed vertically to the skin and stored ones, as shown in the picture. The positive results show as pruritic wheals within 10 minutes after provocation test. Because of the different lengths of pins, we can determine the trigger threshold by freak test and also use it to monitor the treatment response. The third one is the test of the dilapidation Dicario. The principle of testing is the application of a sustained pressure to the skin. In this workshop, we test by wet blood in 5 kg, place vertically on the forearm for 10 minutes. After that, the response should be assessed approximately 4 hours after provocation. The positive results show a swelling at the test site. Some patients may complain about the burning or painful sensation in dilapidation Dicario. The threshold test should be performed in the patient with positive test by using different weights, ranging from 1 to 5 kg. The last one is the photo test in solar Dicario. In the beginning, UVA should be started at 6 June per square centimeters, and UVB at 16 millijoules per square centimeters. Visible light can be used to the further test by using the light projection. In solar Dicario, the positive provocation test shows Dicario wheals with itchy or burning sensation at the exposure site within 10 minutes. It's very important to advise our patients to avoid sunscreen and photoactive medication before testing. According to other symptoms, the threshold testing should be performed in the patient with a positive result by using varied dose of the radiation. After attention of this workshop, I think the information is very useful in practice to take care of the patients with urticaria and edema. I can determine the disease activity and use it to monitor the treatment response. Moreover, I understand the good technique of provocation test better. Finally, I would like to say thank you to all of you about providing me the material to prepare this presentation. I want you to know that I really appreciate this. Thank you.
Thank you, Dr. Achuda. There was a really very nice overview of the patient-related outcomes now that are really very important, and specifically the second part on inducible urticaria, which is not so easy to try to do it right in your office. And thank you very much to learn us again about the details of that. And thank you also for keeping strictly on time. Really very much appreciate. Let's continue now with the fourth speaker. This is Dr. Isabel Oveta from Chile, and she's going to present us the details of the oral presentations. Again, I'd like to stress here that we asked the presenters now to allow us to present their data. Some of them didn't allow us because it is unpublished data. So it's only the selection of what we are allowed to show you, what we are showing here now today with you in this webinar. Dr. Isabel.
Thank you very much. I'm very happy for the invitation of our UCARE team and to be here today in this webinar. I have called my presentation State of the Art of Urticaria, and my principal aim is create an integrated vision from oral communications. This aim is creating an integrated vision on the state of the art from oral communication present at the UCARE 2021 Congress. Regarding the methodology, to present this integrated vision, I have grouped the presentations into the following 5 thematic groups. First, group 1, called clinical and histopathology. Group 2, endotypes and phenotypes. Group 3, molecular biology. Group 4, artificial intelligence. And group 5, clinical tribes. Let's start with group 1, Regarding this group, presentation based on clinical and/or histopathological aspects were included in order to look for associations with different outcomes of urticaria. In this first work by Dr. Grillet of the Berlin group, they wanted to evaluate the role of tight junctions in sweat leakage in cholinergic urticaria patients. They found that in patients with cold urticaria versus healthy patients, there was an exchange of Claudin 10 for occludin, like this, okay? But without sweat leakage. They did find a dysregulation in the composition of the sweat, evidenced by potassium concentration in the sweat. So, in the next work, they wanted to evaluate endothelial change in patients with urticaria and urticaria vasculitis, where post-inflammatory hyperpigmentation was common. They found that this continued in the endothelium after staining for CD2031 would be suggestive, although not specific, for urticaria vasculitis, disease severity, and pure response to omalizumab, according to the findings of the Turkish group by lead Dr. Emek Kokaturk. Regarding clinical characteristics that associate metabolic syndrome with urticaria, the Indian group evaluated different parameters. All of those associated with metabolic syndrome only: abdominal circumference, central obesity, which was higher in women, and in men there was less variation in blood glucose, were associated with urticaria. In conclusion, there are features of metabolic syndrome in patients with urticaria, but not complete syndrome. Finally, in this work, the researchers studied the association between sera omalizumab concentration and treatment response and identified predictors. Dr. Thompson and his team saw improvement in all pros with omalizumab peak at 7 days, with an increase in concentration over time. Predictive factors of poor response to omalizumab was only significant for BMI. Finally, other topics were discussed in the oral presentations where data regarding the definition of new histopathological parameters for the differential diagnosis of urticaria and development of new tools for treatment of the disease were shown. A take-home message from Group 1 is that the comprehensive management of our patients includes the research and understanding of their clinical associations, as well as the use of histopathological techniques that allow us to define responses to treatment and causes of the disease. Okay. Moving forward into the second group, here we group presentations focused on the presence of markers that allow us to characterize patients at molecular or phenotypic level, and we call this group endotypes and phenotypes. In the first presentation, conducted by Ezra Sarak, 3 endotype groups were defined based on IgE and anti-TPO levels. Multiple parameters were measured, but only difference in age was statistically significant. However, other parameters showed some tendencies in line with previous reports. They proposed endotyping using total IgE and anti-TPO and prospective studies with more patients. For the other hand, Dr. Morinho and her team wanted to generate a model to define endotypes associated different clinical factors and treatment. Initially, they achieved an association of BRA with higher disease activity. It's proposed to gradually incorporate other markers like clinical, histopathological, laboratory, and others that allow characterizing patients and defining the response to treatment. Here we see the association between BRA with disease activity. Finally, Data regarding other topics such as difference between adult and pediatric population were shown to be under study in this conference. The take-home message from Group 2 will be that the multiple pathways of mast cell activation and the participation of biomolecules during the process help us to understand the different endotypes that can be seen in the different patient phenotypes. Group 3 brings together the talks that had in common the use and advances in molecular biology regarding urticaria. As we know, the key cell in urticaria is the mast cell that can be activated to the granulation by extrinsic factors and immune alterations, such as autoallergy and autoimmunity. This alteration can occur by direct interaction with cell receptors from extrinsic factors and can be also mediated by autoallergens, such as anti-interleukin-24 IgE or immunocomplex that can, for example, interact with high-affinity IgE receptor. All these triggers signaling cascade within the mast cell that lead to activation and degranulation. The release of these granulates induce inflammation, vasodilation, favoring the highest formation and/or angioedema. And it's important here other cellular pathways can interact and contribute to the disease, for example, the extrinsic coagulation pathway. Each one of these molecular features of urticaria are a subject of a study discussed during the oral presentations with implications in the understanding of the pathology and possible better treatments. So the take-home message from Group 3 is that molecular biology opens paths that allow us to better understand the chronic urticaria and how its pathology is immersed in autoimmunity. Group 4, artificial intelligence. In this section, I group the presentations that talk about machine learning. I'm going to talk about the machine learning tool, since it has been proposed as useful for the prediction of clinical parameters of urticaria during the oral presentations at UCARE 2021 Conference. What is the machine learning? Let's suppose we have a database of patients with measurable parameters and their outcomes, such as the one here. The machine learning is a tool that allows us the prediction of outcomes for subjects with no known values, such as patient X. So the software will calculate a predicted value for the outcome based on all the other parameters and will associate this value with measured outcome for the patients. Okay? If we have several data from patients, the software will be able to learn from its mistakes while predicting the outcome and so improve the predict algorithm. After this learning period, the software will predict the outcome for a subject whose outcome is unknown, such as patient X. This could give us light about not measured parameters in some patients. This is the importance of machine learning. The take-home message from Group 4 is multiple factors such as clinical and/or molecular constantly interact, triggering the heterogeneous disease of urticaria. The knowledge and study of these factors and their interaction through machine learning can be a useful tool for clinicians in the future. And the last group brings together the clinical trials they presented at the meeting. There were oral presentations about ongoing clinical trials that are in phase 1B or phase 2. These works are oriented to the study of several molecules such as KIT receptor blockers, BTK inhibitors, and IgE blockers. The clinical response of the patient was measured by provocation test, UA7, and mast cell activation levels. These trials were conducted in adult and adolescent population with different types of chronic urticaria, such as CSU or CINDU, this last one divided into cold urticaria and symptomatic dermographics. So the take-home message from group 5 is that several clinical trials are being conducted in order to offer new and better treatments to our urticaria patients. As a conclusion, knowing the state-of-the-art of urticaria is crucial. In this way, we will understand the factors that interact in the pathogenesis of urticaria, achieving a greater study of patients and offering them better treatments. And to finalize, my personal message is that the answers to all the questions that gave life to these talks are in our patients. The correct and efficient use of clinical history, laboratory tests, histopathological techniques, and bioinformatic tools will allow us an updated and an individualized management, generating a virtuous circle of medical care, carrying out the best medical practice for our patients. Thank you for your attention.
Thank you very much, Dr. Isabel Oveta. I think that was amazing how you could summarize so much stuff presented during the and divided in the 4 different groups. I think that was a great job. Really, thank you so much. I don't know, I'd like to invite the public to put in the chat, and thank you for so much. Hi, here I am from so many parts of the world. You really see them all there. But if you have a question, please put it in the chat, and we now still have some 4 minutes to communicate with our presenters. If not, I'd like to start with one of the first questions is to Dr. Pavel. Specifically related to the presentation of your poster, do you think there still is a role for autologous serum skin testing in CSU patients?
Thank you, Désirée. Actually, this is a quite interesting question because as was proposed, we need 3 positive tests, in order to diagnose type 2B CSU. So basophil tests, immunoassay for IgG autoantibodies, and also SST positivity. But recently it was shown that SST is not a good marker for diagnosis of type 2B. Maybe the best single marker for diagnosis of type 2B is basophil histamine release assay or basophil activation test. But my personal opinion, because I read a lot on this, I think that, and there is also a confirmation of what I'm going to say in the recently published paper, that we need to use SST positivity in combination with other markers, not necessarily BAT and immunoassays, but maybe other markers like low total Ig, high IgG and TPO, maybe basopenia, eosinopenia. So we need to find a best combination which can allow us to predict or to diagnose type 2B CSU.
Yeah. Thank you very much. Yes. Dr. Monica, I was intrigued by also the importance of eosinophils. No, we also always have been thinking about mast cells and basophils, but now you clearly also show that eosinophils have their role, and maybe anti-eosinophilic therapy. Could you give a very short word on that?
Thank you very much. Yes, there are very interesting ongoing clinical trials now, some of them in phase 3, where the type 2 inflammation as a whole is being targeted, as in terms, of course, many of the biological treatment targeting specifically to eosinophils. So maybe the mast cell may start the inflammatory response, but the cross-communication that it keeps up after recruiting the eosinophil and after this being activated is very important. So it's a key cell. Yes, we should look at and listen to what this cell has actually to say.
Thank you.
And eosinopenia, we should, of course, always consider it. And just to all attendees to remember what the low values are considered to be less than 50 from the blood cell count in terms of eosinophils. When we turn into basophils and basopenia, we can consider it less than 20, but sometimes even low as 0.
Yeah, yeah. Thank you very much. And a very quick question to Dr. Achuda, or more remark. I see there's now also patient-rated outcome measures for cholinergic urticaria specifically. Now, and my question was only, have you translated any of these into Thai? Do you have these tools in your office?
Translated to Thai language by using the cholinergic urticaria questionnaire or not. I think because cholinergic urticaria in Thailand is not
so
it's not the patient is not many to validation or to to validate the Thai version. But I think because now I know the information of the physical urticaria much more than the past, so that I will I think we have the test. We have the test to confirm test the cholinergic urticaria. So that I think again the patients in the future, and maybe to validate about this question in the future.
Yeah. Okay, yes, sure, absolutely. And then the last question to Dr. Isabel. It was interesting to see that there was definitely a relationship now that omalizumab was a little bit less effective in patients with higher BMI. So I think this also stresses the updosing that the latest urticaria guideline allows us to do with omalizumab, although it's still off-label. Could you give just a one sentence remark on that, because we're just a bit over time?
Okay, thank you, Désirée. Yes, in this work that I present about relationship omalizumab concentration and poor response to omalizumab in patients with higher BMI, I can discuss that maybe it's necessary updosing the dose in these patients, not only in the short interval of treatment. Maybe I think can updosing the third from exactly from 300 or up to 600 by month. Okay, it's possible, not defining to today in the guidelines, but it's possible.
Yeah. And actually, the latest guidelines allow us to even go for 600 every 2 weeks, which I considered quite high, but it's in there. So thank you very much. I think we really had an amazing a lot of presentations from the 4 of you, and I'd like to invite the public, those who are not yet a UCARE center, please have a look at the UCARE LevelUp website, where you can find a lot of more information, and also the GovNo. It's already out there, the invitation to the next Global Urticaria Forum for those who are really interested in urticaria. This is really fascinating to be there, to discuss with the colleagues from all over the world, and this is going to be by the beginning of December this year. Thank you very much again for your attendance. We had over 100, 115, I think at some point, attendees here from all over the world, and we'll again meet in the next webinar. Thank you.